My name is Armin Kalenka. I am head physician of the anesthesia and intensive care units at the Bergstrasse District Hospital, an institution of Heidelberg University Hospital. Our facility has 310 inpatient beds, with another 13 beds in our interdisciplinary intensive care unit. Before we get to the practical application of our treatment approach to lung protective ventilation, I would like to briefly describe the theoretical aspects behind it. What does lung protective ventilation mean for us? We have known for decades that invasive ventilation saves lives, but unfortunately can also cause injury. We are therefore attempting to ascertain for each patient, based on the concept of stress and strain, the optimal pressure and volume levels that will ensure respiratory gas exchange but not strain the lung with too much pressure or too much volume. How does invasive ventilation cause injury to the lungs, which we refer to nowadays as ventilator-associated lung injury? If the pressure and tidal volume are too low, atelectatic trauma, hypoxemia, or impaired decarboxylation may result. If, however, the pressure and volume are too high, the result may be pulmonary barotrauma and volutrauma, which in turn may lead to ventilator-associated lung injury. Ventilator-associated lung injury was first described exclusively in patients with acute respiratory failure. Today, however, numerous studies show that it can also occur in patients with apparently healthy lungs and without acute respiratory failure. In light of this evidence, we are applying lung protective ventilation to all of our patients who receive invasive ventilation. To provide our patients with the best possible care, we employ an individualized treatment algorithm for lung protective ventilation. In doing so, we are departing from purely protocol-based approaches to treatment. Individual titration of tidal volume and positive end expiratory pressure, Peep, enables us to adjust the ventilator to the specific patient. From the concept of lung protective ventilation, we can filter out three cornerstones. The first is an early recruitment maneuver. The second is individual titration of tidal volume. And the third is individual titration of the Peep level. Allow me to briefly explain these three cornerstones of our lung protective concept. For all of our patients, we begin by performing, within the first 3 days of their artificial respiration, a moderate recruitment maneuver whereby the previously closed atelectatic lung regions are opened up. Then we determine, based on the concept developed by Professor Gattinoni, referred to as the baby lung model, the size of that baby lung. This enables us to ascertain the ventilatable lung volume of each patient for the optimal tidal volume setting. Finally, we take measurements at various Peep levels so that we can calculate the optimal Peep for the individual patient that will enable that patient to keep the previously closed atelectatic regions open. To summarize, we define lung protective ventilation as a process whereby the risks and benefits of invasive ventilation are individually assessed for every single patient who requires ventilation. For the most part, these three cornerstones are crucial to the process: early recruitment of atelectatic lung regions, individual titration of the applied tidal volume, based on the measurement of functional residual capacity, for example, the so-called baby lung, and finally, individual titration of the PEEP level based on a bedside measurement procedure. I would now like to give you a bedside demonstration on a patient of the measurement procedure that makes this individualized lung protective ventilation possible for us. We are now in the intensive care unit. I would like to introduce you to a 76-year-old patient with septic multiple organ failure caused by pneumonia. The first thing I will do is perform a recruitment maneuver, after which I will set the individualized tidal volume and the optimal PEEP for the patient based on FRC in-view and PEEP in-view measurements. So let us begin. Here we have a 76-year-old critically ill patient with renal failure resulting from pneumonia. The patient requires administration of catecholamines and ventilation. The first thing we will do is control the conditions for the measurement of functional residual capacity, FRC. We see that the VCO2 value is relatively stable. We can assume, therefore, that the measurement will be reliable. With the aid of FRC in view, I will now perform a single measurement, 50% oxygen, 10% change, single measurement. I will press the green button and the measuring will begin. Down here you can see that the device has now changed the inspiratory oxygen concentration from 50% to 60%. Thus the measurement is about to begin, and here we already have the first measured value, which is displayed as a green dot. It will now be approximately 20 to 25 breaths before the inspiratory oxygen concentration has finally increased to 60%. We will then have the first value for FRC. And here we have the first FRC value. The device will now reduce the inspiratory oxygen concentration back down to 50% and then take a second FRC measurement in the washout phase. The inspiratory oxygen concentration has now declined from 60% back to 50%, and the second measurement has begun within a few breaths. And here we are already seeing the first value of the second measurement as a yellow dot. It will now be another 20 to 25 breaths before the inspiratory oxygen concentration is readjusted and the second measured value is read out. An FRC of 1,351 milliliters has been calculated. To find out whether the patient is recruitable, I will perform our customary recruitment maneuver, as it is called. To do this, I return to the main screen and take a look at the patient's hemodynamics. Our objective is to increase the set PEEP value by a pressure of 10 centimeters of water, H2O. It is important that this happens gradually. This means that 3 to 5 breaths should always take place at the increased PEEP level. In the meantime, I will check whether the patient is hemodynamically tolerating this PEEP increase. We started at 19 centimeters H2O, So our objective is a PEEP of 29 centimeters H2O.
Im Rahmen des Recruitment-Manövers zu implementieren. Immer ungefähr 3 bis 5 Atemzüge.
Now we see that the alarm has been triggered. The reason for this is that the stored alarm value for our peak pressure was somewhat too high. I am gradually reducing the PEEP again. Until we have reached the initial level, in this case a PEEP of 19 centimeters H2O.
Wir sind wieder bei 19 cm Wassersäule angelangt.
The patient has hemodynamically tolerated the recruitment maneuver well. I will now return to FRC in view and take a new FRC measurement at a PEEP of 19 to see whether a recruitment maneuver can usefully be performed at this level. The device has changed the inspiratory oxygen concentration from 50% to 60% so that the first measurement begins right away. And here we already have the first value. The inspiratory oxygen concentration is then reduced once more from 60% back to 50%. The inspiratory oxygen concentration is now at 50% again, so the second measurement cycle will begin immediately. We now have a value of 1,267. Thus, the recruitment maneuver just performed was unable to achieve any recruitability of the lungs, even though compliance was somewhat improved. This result is not surprising, as the patient is experiencing her second bout of septic shock after 6 weeks in intensive care, during 4 of which she was artificially ventilated. We are now done with the FRC in-view measurement and can begin the PEEP in-view measurement. For this patient, we are starting with a PEEP of 19. This means that we would begin the decremental PEEP trial with an upper PEEP of 24 and end with an end PEEP 5 increments below the current PEEP, in this case 14. We will automatically perform 5 measurements with a duration of 5 minutes per level. It will be a while before we are able to look at the results in detail.
Wir werden uns die Ergebnisse im Folgenden ansehen können.
The PEEP in-view measurement is now finished. Here we have our PEEP value with a start at 24, our end PEEP at 14, 5 measurements over a period of 5 minutes per level, and over there we can read the individual values for FRC, PEEP, and static compliance. At the top we see everything displayed again in the form of a graph. We have now seen how the bedside measurement procedure is performed. All that is missing now is an analysis of the results, which we will now perform together. The first thing we see on the ventilator screen is the measured functional residual capacity. This is, in formal terms, the end expiratory lung volume, as the patient is being artificially respirated with a positive end expiratory pressure of 19 centimeters H2O. Our colleague on the night shift set a tidal volume of 350 milliliters for this patient. Based on the stress and strain concept already mentioned, we will now ascertain our patient's own unique strain value, as it is called. This is calculated by dividing the applied tidal volume, in this case 350 milliliters, by the end expiratory lung volume of approximately 1,350 milliliters. The result is a value of 0.25. If this value were greater, there would be, according to scientific studies, a sharp increase in the incidence of ventilator-associated injury. Once we had reviewed the basic settings, I performed a moderate recruitment maneuver on the patient in the intensive care unit to determine whether there is any lung recruitability present. After that, we applied what is referred to as a Peep in-view measurement procedure. In our ward, we traditionally perform what is called a decremental Peep trial to prevent atelectasis formation during the measurement. We started with a Peep of 24 centimeters H2O, and after 5 measurements, we then ended the trial at a Peep of 14 centimeters H2O. We had performed a recruitment maneuver on our patient beforehand, and now we can read the recruitment result directly by means of the measurement. Before the maneuver, we had detected an end expiratory lung volume of approximately 1,350 milliliters, and now at a Peep of 19, we can detect an FRC of approximately 1,620 milliliters. Thus, a recruitment result can be achieved right at the patient's bedside. I would now like to illustrate for you on the basis of 3 cornerstones how we set an optimal Peep for this specific patient. As you can see, a Peep increase from 22 to 24 does not result in any significant increase in end expiratory lung volume, though it does result in a marked decrease in compliance. A Peep increase from 14 to 19, on the other hand, results in a marked increase in end expiratory lung volume and produces no significant change in compliance. Based on these results, we would now specify for our patient an individualized Peep of 19 centimeters H2O, as for one thing, the best end expiratory lung volumes are present at that level, and for another, there is no detectable change in compliance. It is these bedside measurement procedures that permit us in our daily clinical practice to apply lung protective ventilation to all of our invasively ventilated patients.